Hello, and welcome to our discussion on heart blocks. We're going to particularly talk about the four different heart blocks. They're AV node blocks. This is when there's a delayed or failed conduction of impulses through the AV node that would lead into the ventricles. So in these situations, the conduction through the heart is either going to be decreased or slowed or halted or stopped. The PR interval in these types of heart blocks is going to be key. So we're making sure we look at our PR interval. So we'll talk about the least, the least acute first. We'll start with the first degree AV block. I say least acute because it doesn't always require intervention. Neither does the second degree AV block type 1, which is also called Wenckebach or Mobitz 1. When we start to talk about second degree AV block type 2 or Mobitz 2, they're more serious, and so is the third degree or complete heart block. So let's talk about them. Okay, so this one here, we are going to look at the left side of the screen. And this is a normal sinus rhythm on the left side of the screen. You can see that there is a P for every QRS. The PR interval is less than that 0.20, which is where we want it to be. Our QRS is less than that 0.10. And our T waves, they look decent. They're okay for now, so we'll deal with that. And it looks like a beautiful sinus rhythm. You can count your rate on here, 70. Now let's look to the right of the screen. And we have here what's considered to be a first degree AV block. So to classify as a first degree AV block, if you look right away and look at your P before every QRS, make sure that there is one and it's consistent for every complex. So you have a P, QRS, T, P, QRS, T. Now you go to map and measure your PR interval, and you will notice that the first one there is greater than 0.20. One big box, again, is 0.20. So if you're looking at the second one, you'll see that your PR is greater than 0.20, and so forth. And you'll notice that your PR interval in the second rhythm strip is consistently greater than 0.20, and it's the same measurements for each PR interval here. So our QRS is normal. Our rate looks like it's about 70. So we have a normal sinus rhythm because the impulse is coming from the sinoatrial node because we have a P wave. So we have a normal sinus rhythm with a first degree AV block. Not usually symptomatic, these patients. Sometimes it's like med related, maybe some beta blockers or DIG. A lot of times DIG is the culprit in these things. Sometimes hyperkalemia, congenital abnormalities contribute to this. Basically, the treatment is if the patient has symptoms, like let's say they become severely bradycardic, then we'll follow our bradycardia protocol with the atropine and maybe pacemaker if they needed it. This is not usually the case with first degree AV block. But the problem with a first degree AV block is it can progress to a second degree AV block. So let's move on to that. So a second degree AV block, again, there are two types of second degree AV blocks. There's second degree type 1 and second degree type 2. Right now, we're going to talk about the least, severe out of the two of them, which is the type 1, second degree, also known as Wenckebach or Mobitz 1. People will often call it Wenckebach, so that may be the most common way that you hear it. If you look to the left, both of these strips are that rhythm, the second degree AV block. The first strip you can see here, let's look at our P. Make sure we have a P for every QRS. I see 1 P QRST and 2 P QRST, 3 P QRST, and then I see a P, and then a beginning of a next complex. If we map out our QRS, it's normal, it's less than 0.10. Let's measure our PR intervals in the first strip. Our PR interval here looks like it's about 0.16-ish. And then the second one looks like it's about 0.22. And then it gets a little bit longer, and then it finally drops. So long PR interval, longer, and then it drops. And then look, it starts back up again. So look at your second rhythm strip here. We have a long PR, we have a longer PR, and then a longer PR, and then the beat completely drops, and then it starts back over. at long, and then I anticipate the next one will get longer, longer drop. So typically in this type of rhythm, we say this little rhyme that you'll learn about at the end. We say long, longer, longer drop. Then you have a winky bach. So that's how you can tell that it's a winky bach. It goes long, longer, longer, and then it drops. So the rhythm is irregular, as you can see there, because there are missed beats. The rate of the atrium and the ventricle is going to be determined by the underlying rhythm. So it's going to vary. It can be slow. The PR interval progressively lengthens, normal QRS. The P waves are normal, they're there. And the PQRS in ratio is not measurable. This can be caused by like hyperkalemia again, DIG is a big one, beta blockers, calcium channel blockers. But we're real careful when we see this as a new rhythm because it could indicate that there is an acute inferior MI happening. So, and that leads to AV node ischemia. So that's not good because this could progress and they may need treatment. They may not be having a symptom if they're having an MI. So we're real careful when we see this, particularly when it's a new rhythm. Usually they're asymptomatic, unless again, if they're having an MI. Or if they've had one in the past, they may be something they live with is this type of rhythm. If they are symptomatic, like let's pretend they become bradycardia, then we again would follow the bradycardia protocols. Atropine up to our max of 3 milligrams, like we talked about before. Maybe they can get a pacemaker if that's what they need. So we look at their symptoms. Are they having symptoms? Do they have good cardiac output? From what we can tell, are they sweating? Are they have good strong pulse? Do they have good blood pressure, level of consciousness, and all of those things we're looking at, to make sure that they're stable. And if they're not, then we intervene with our bradycardia protocol and treat that if that's the case. Second degree type 2 is AV block is also known as Mobitz 2. Now I was telling you before, this is where it's going to get a little more serious. Things are going to get trickier here because patients can be starting to decline when they progress into this type of heart block. So again, it's called a Mobitz 2. You'll note in this top strip and bottom strip, you'll see a PR interval, a beautiful PR interval. When it's there, it is normal. It can be a little long sometimes, but generally it could be normal. But when you do see a PR interval in this rhythm, it's consistent. So you see your first PR interval in this top strip, your second PR interval, and your third PR interval, all the same. They're all the same. They can be long, they're just consistent. No matter what it is, the PR will be consistent when it's followed by a QRS complex. You see the third rhythm complex in this Mobitz 2, the top strip here, there is no QRS. So that P wave did not conduct. There was no QRS that came after that P wave. So for this one, you can see a normal PR interval, normal QRS complex. It can be wide sometimes, but generally you're looking at your PR interval. You'll see one, and when you see it, it's consistent between all of the complexes that conduct, and then you will see a dropped beat. In the bottom screen here, you see a PR interval, and then you see a dropped beat. Then you see a PR interval with a QRS, another PR interval with a QRS that's wide, and then a P with no QRS, and then a P with no QRS, and then again, it picks back up. So sometimes it can drop every other beat, so you may see a P, QRST, and then a P, and then nothing, and then a P, QRST, and so forth. So the rate of conduction is going to vary. It can be a 2-to-1 conduction pattern where you see 2 conducted beats and then 1 dropped beat. It can be a 3-to-1, things like that. So you're looking at, I always look at your PR interval, okay? So when it's consistent and when one is dropped, then that is a Mobitz 2. So the symptoms for this, they're usually related to the ventricular rate, because sometimes that ventricular rate is slower because we're not having as many beats. So the patient, can have a slower rhythm, and the PR interval, although constant when it's not there, depending on how many are missing, the patient can have symptoms. So we may need to treat these patients. Often we do when we see this. It's not a real common rhythm. It's less common than the 3rd degree heart block we'll talk about, but it is more serious than the 2nd degree type 2. The issue with this is that the patient may suddenly progress to the complete heart block or asystole. So we're real careful when we see this rhythm. Reasons for this rhythm, Patients can have had an anterior wall MI. Their electrical conduction system can be older. Like, so some older people can have this, ischemic heart disease, myocarditis, other things like that. Generally, we're thinking maybe an MI happened, or maybe the patient, this is their baseline, not often, but sometimes you see it. So we look at the patient always, feel the pulse, get the blood pressure, get their symptoms, and see how they're tolerating it. If this is new, of course, we're going to report it because, again, the patient could be having an anterior wall MI. So pacemaker, perhaps we may need to do a pacemaker for them transcutaneously if it's urgent. We may need to eventually put in, if we can't correct the underlying cause, a permanent pacemaker. Okay, so it all depends on their stability. Okay, now here is the most serious of the heart blocks. This is a third-degree heart block, or also known as a complete heart block. This is what I think of it as. They are completely broken up, like the AV node, the atrium and the ventricles, they just do not communicate anymore. So you can see in this top rhythm here, there's a complete absence of conduction through the atria and the ventricles. You'll see that there's a P wave up top in red, then there's a QRS, and everything looks good, you would think. And then you see your T wave, and then you see an immediate P wave again. I don't see a PR interval for that second one. So now I'm seeing another P wave, and then a QRS, and then a P wave. So if you were to get your calipers and march out your P to P interval, it would be consistent. So you'll see the P's marching along at their own rate consistently. So if you count it, and you can see the red arrows here, there's a consistent demarcation between each P to P intervals, and they are the same. They look like they're almost about three big boxes about-ish, but they're the same for each P to P interval. If you see your R to R interval, you note that they are consistent. You see that there's a big amount of space between your R to R interval, but it's consistent. So these P's are beating independently of these QRS complexes. They are doing their own thing. So as you'd imagine, the ventricular rate is going to be slow because this impulse is coming from further down in the ventricles. Remember, the ventricles are paced by either the AV node at a rate of 40 to 60 beats per minute, or the ventricles, if it gets that low, at a rate of 30 to 40 beats per minute. Remember, the atrium are going to be paced by the sinus node at a rate of 60 to 100. So you can see that there's a lot more P waves compared to QRSs here. And when we're counting our rate, we're counting our QRS complexes within that 6 seconds. So in this one, it looks like about 50 beats per minute. Symptoms will probably be there. So this patient is going to need emergent pacemaker therapy. So we will do a transcutaneous pacer on them, perhaps even a transvenous if we can't get them immediately to a permanent pacemaker. So check your symptoms on your patient, and this can progress. So be prepared to intervene with a transcutaneous pacemaker until we can get this patient to a permanent pacemaker. Often MI is the cause. It could be actually anterior or inferior in this situation, and that would require intervention. Some heart diseases, cardiac surgeries can cause this rhythm temporarily or permanently. So again, check your patient. They may need a permanent pacemaker or a temporary transcutaneous, depending on the underlying cause. And if we can correct the underlying cause, that's great. Again, digoxin can be a culprit here. So we're always looking at our DIG, signs and symptoms of toxicity of DIG. Before we even get to this point, do they see halos around the lights? Are they having nausea, vomiting? What is our current DIG level? And know your regular DIG levels. That way you know if they're toxic. So symptoms usually, they can progress pretty quickly. They can become weak, dizzy, and if it abruptly starts, if a patient goes from like sinus to third-degree block, they're usually doing poorly. Something is causing that, and they can have an abrupt progression into asystole. So this is a serious rhythm. And you'll see we take this very seriously in the hospital setting. We're ready to pace these patients and get them down for permanent pacemaker. And again, if we can fix the underlying causes, that's great. So here's a helpful poem about the differentiation between the heart blocks. If the R is far from P, then you have a first degree. So remember, this is where you have a consistent PR interval, and it's long, but it's consistent for every single complex. It's always there. The P is always there. It just takes a little while to get to that QRS. Longer, longer, longer drop, then you have a Winkie Bach. So if your PR interval gets longer, longer, and then drops, and starts back over again, we have a second degree type 1. If some P's do not get through, then you have a Mobitz 2. So again, this could be a P, QRST, P, QRST, and then a P, and then no QRS, so non-conduction. So when the PR interval is there, it is consistent, but they just don't all get through. So you may not see a QRS after a P every so often in Mobitz 2. If P's and Q's do not agree, then you have a third degree. So this is where you're marching along your P waves and you're noticing there's no consistent PR interval, but the P to P interval is consistent. And the QRS, like the R to R interval, is consistent. Because they're marching along independent of each other. They have broken up. So this is complete total heart block, need a pacemaker, get this patient stable. Always check your patient for all of these because first degree, although not always unstable, they can have some bradycardia. So we're always, again, check your patient, look at the monitor, what is their baseline, what are they doing? And then we decide our care from there. And that is the end of the consultation. We will practice some rhythms in class.